Hello everyone. Welcome back to the Advent Health Nicholson Center. I'm Scott Magnuson, a head and neck surgeon here at Advent Health Celebration. This is part 2 of our 3-part series of transoral robotic surgery. Today, I'm going to perform a dissection on the tongue base. We're going to perform a tongue base resection for tumors. As the US FDA has approved transoral robotic surgeries for early stage cancers, T1, T2 tumors, as well as benign. And so today we're going to do a demonstration of a tongue-based resection for a tumor. Today's platform is the Da Vinci Xi platform. In the United States, this is not FDA approved. However, it's a platform that's used worldwide. And I wanted to make sure that we use this platform for our international guests so they can have some experience watching this platform today. I want to thank the sponsorship from Olympus. Helping us have these webinars is it's very important to supply this information during this COVID pandemic, where we can still get information and education out to the people who are interested. So thank you, Olympus. So we're going to start with the exposure first. I'll place the retractor into the mouth, exposing the tongue base. Then we'll dock the robot. Once we put the robot in place, I'll move to the console and perform the tongue base resection. If you have questions during this, you may put them in through the chat. I have people looking at the chat talk, and I'll take some pauses at each section to answer any questions from the audience. So we'll begin. So the first thing is we're going to place the retractor in its position. We have the robot partially in the correct location, but I'm going to move the arms out of the way just so we can have some space. And if you notice, once we get the camera inside, this patient has been, this was the patient I performed the limited pharyngectomy on at our last series, our last webinar. And so I performed a right lateral oral pharyngectomy. So today we'll work so that it's an undisturbed size. We'll focus on the left side of the tongue. I start out by placing a stitch. The stitch is already in the tongue. This stitch allows for us to manipulate the tongue with any procedure, whether we need to retract the tongue or move it to the side. It helps us to move that tongue in its proper position. With the blades, there are different types of retractors. Olympus makes a retractor called the WOFK. There's also a retractor made in the US by a company called Med Robotics. Their retractor is called the Flex retractor. There is an international retractor from Belgium called the Lars retractor. And then, of course, we have our standard oral mouth gags, the Crow-Davis, etc., that can be used. For lateral oropharyngectomy, I think it doesn't really matter the retractor. Even the most common Crow-Davis, for example, could be used. But as we get deeper in the aerodigestive tract, it's better to use these more sophisticated retractors to get the exposure that's needed. So I'm going to go ahead and place this retractor on the tongue. The difference with tongue-based surgery is we want to have exposure of the tumor for sure, but we don't want to necessarily cover the entire tongue. So we want to have the tongue base in our view. We don't want to move the tongue base out of the way. For example, in our next series, when I perform the supraglottic laryngectomy in October, I will move the tongue base out of the way. But in this case, I want the tongue base in the view so that my tumor can be completely exposed. Before placing the retractor, I always do a digital exam, and I feel the tongue base, I feel the tumor to get an idea of the thickness and of the amount of tongue base that I need to expose. And so when placing this, I place the retractor in the mouth. Usually what I do first is I have some gauze. This patient is edentulous, and so there's less worry about protecting the teeth. But typically I place a gauze 4x4 and the upper alveolar ridge, And I also place one, especially for those patients who have teeth, I place one along the lower teeth so that when I pull the tongue out and retract the tongue does not become pressed against the teeth, and you can avoid any laceration to the ventral aspect of the tongue. So placing the gauze in the mouth first, and then I place the retractor. So getting the retractor on the alveolar ridge, upper alveolar ridge. Making sure I have tongue base exposed. I need to see these blades. And you have to adjust with different blades, with different retractors, just so that you can make sure that you have the right size or the right fit for the patient. If you have a smaller patient, some of these blades may be too large. Do we have a Dingman available? Dingman? It's the other mouth gag? Babs, do we have those other mouth gags that we use for osis?
Yeah, Brian just wants to go grab them.
Okay. So I'm checking the different blades to see which one might be the most adequate for the patient. And again, I'm favoring so that the left tongue base is exposed. We're good. Ryan, we're good, thank you. And once I get that in position, we bring in something to hold and suspend the retractor on, and in this case, we're going to use a Mayo stand. So the Mayo stand is brought in. Yep, thank you. Okay, and now the patient is suspended and we have good exposure. So I'm looking here in the oral pharynx. I see that the tongue base is exposed, and now it's time to place the robot. So I'll pause for a second. Do we have any questions from the audience? Not yet. No questions, okay. So the Da Vinci system is set up with 4 arms, but with TORS, we only use 3 of the arms. And with the XI system, the arm that I stow is the arm that's closest to the center column. So I'll move arm number 1 away, and I'll stow this arm off to the side, and we'll just use arms 2, 3, and 4 instead. I put the arms in a general location of where they're going to be positioned during the operation. And, oh, I forgot to do one thing. Brandon, we need to drive the hash mark over our, there's a laser that aligns the boom of the robot in its proper position. So go ahead and hit the, and you're going to come forward, continue to come forward, and you bring it down towards the feet a little. Okay, that's good. Now come forward. Continue. Keep coming, keep coming. You have about this far to go still. Yep, continue, continue, continue. A little bit more. Right there, that's good. Okay, so now we've got the boom in its optimal position. And I'll place the arms in their generalized location. before placing the cannulas and the instruments. So we're using 3 arms. We have a camera for the center, and then the working instruments are on either side. The cannulas are placed next.
Install the endoscope for targeting.
And now with the placement of the cannulas, we're going to put the camera. So on one of my webinar series a couple of months ago, the whole series was about docking and the proper positioning for each of the different locations of dissection. So we have the lateral oropharynx, which is the most proximal in the aerodigestive tract. Then we have the tongue base. And then finally, the most distal is the supraglottic larynx and the hypopharynx. As we move more distally in the aerodigestive tract, the arms come closer together because you have less working space and you have more opportunity for collision and more difficulty with moving the instruments in the arms. And so there's a strategy to kind of overcome some of that situation. One of the strategies is the camera. So if the camera is, in this case, a 30-degree upward-facing camera, it can be in a different plane than the 2 instruments. And so we'll demonstrate that now. So we place the 30-degree camera in its position. And so it's 30 down. If you press they're doing this, there we go. From the monitor, they adjusted the scope to 30 up. The team did. And so now I'll take, with a 30-degree upward-facing camera, the camera is not going to be exactly parallel with your retractor. It's going to be more vertically oriented. The other thing I do is I do not have to place this cannula all the way into the mouth. The closer these cannulas are to the mouth, the more compact our working space is with these arms close together. So by bringing the cannula out of the mouth, we can open up the space between the arms. So the cannula is approximately 8 to 10 centimeters out of the mouth, and I advance the camera, and I have a monitor where I can see my working area. I see the circumvallate papillae there demonstrated, and so the camera's in its position, and I go ahead and lock in position. The next are the instruments. As a general rule, I place my retractor, which is typically a Maryland dissector, on the contralateral side of the tumor, and I place my energy device, which is typically a monopolar spatula-tipped electrocautery, on the ipsilateral side. And so in this case, since I'm doing a left tongue-based resection, I'm going to put the monopolar cautery in my left arm. Come through here. Yes, while I'm placing this, there's a question.
How do you earth your metal cannulae monopolar ports?
I didn't understand. Say it again. Can you repeat the question?
It says, how do you earth your metal cannula? How do you ground your monopolar port?
How do we ground the monopolar port? So the patient has a grounding pad on the skin. Typically, we place it on the thigh or the buttocks for the grounding pad. So I have my monopolar in my left arm. We have our Maryland dissector going in the right arm. Now, with the XI system, the Maryland dissector also has bipolar energy, which is very helpful because you can manage smaller vessels with bipolar electrocautery and help with the bleeding in that case. So as I bring these instruments now and these arms to their position, I imagine the trajectory of the instrument as it's going towards the tongue base. And I'm looking directly, myself, I'm looking directly in the oropharynx. And I know that if I was performing the operation, then I would be having my hands come in this trajectory, this angle heading right towards the tongue base. Well, these instrument arms represent our own arms, our own hands. And so I'm going to place them in a similar plane as I would with my own hands. So I place the instrument in the position. I bring the cannula, again, about 8 to 10 centimeters from the patient's mouth opening. And I do that with both instruments. And I can directly visualize the placement of these instruments and the angle and the trajectory towards the tongue base. So as I'm placing them, I can advance them. I check for range of motion. I check for any potential collisions before I even get to the patient's, before I even get to the surgeon console. And I assess how satisfactory the position is. And I like this position here with that instrument. So now I'm going to check my Maryland. I'll check for range of motion again. I assess for any potential collisions. I see none. And so now my instruments are in position. So if you notice here, our camera from a side view, our camera and our instruments are at two different planes. Our camera is more vertically oriented and the instruments are more horizontally oriented. If you also take a view from behind me, you'll notice that the instruments on either side are relatively close to each other. Because as I said, as we get more distal in the aerodigestive tract, our arms have to come closer together because our working space is smaller. If we're up in the oropharynx, we have plenty of working space, but as we get down into the aerodigestive tract, we have a more narrow working space. The pharynx is like a funnel. It's not a complete cylinder all the way down. It's wider at the mouth and narrower down by the larynx and hypopharynx. And so we're working in that funnel. And so your instruments are narrower, are closer together. The space between them is narrower. So now we're ready to move to the console. Do we have any questions to this point about docking and instrument positions?
How close is the camera to the base tongue?
How close is the camera to the base of tongue? The camera is actually sitting very close to the palate. So it's just hovering above the palate, but because it's a 30-degree camera and it's upward facing, it appears to be looking down towards the tongue. I have at least 5 centimeters of space between the camera and the tongue base. Now, that being said, during the operation, I move the camera constantly. It does not stay in a single position. There are studies in other specialties that look at how often surgeons clutch during an operation. And the more novice the surgeon, the fewer clutches. The more advanced the surgeon, the more clutches. And so I'm constantly clutching my camera to get the optimal view. And I'm also clutching my arms, so I'm in a very relaxed position. So that's happening throughout the entire operation. Okay, so I have an assistant who will come and will manage. Oh, I forgot one thing. I need to put a nasal pharynx suction in. So can I have those gloves again? Thank you. So for smoke evacuation, one of the tricks that I perform is that I place a nasopharyngeal catheter tip suction into the pharynx. And I can see that directly. Okay, so that I place that, and that helps with smoke evacuation. And by a general rule, all of the patients are intubated with a nasotracheal intubation. So I ask the anesthesiologist to use a nasotracheal ray intubation. And typically I ask them to place the nasal ray tube in the contralateral nair to where I'm working. So if I'm doing a left tongue base, I ask them to place the nasal ray in the right nair. That allows for the endotracheal tube to be slightly moved to the left side. It still sits along the posterior pharyngeal wall, but it's slightly moved to the left side. And it also allows me not to have additional tubes in the mouth that I may be competing for working space. By placing it in through the nose, it's out of my working space and I'm not competing for that working space. So my assistant's going to come. So in robotic surgery in TORS, one of the advantages is you have an assistant at the bedside who has two instruments, typically a suction or some retractor in the other hand, and then the robot itself, we're having two instruments. So working in the tongue base, I, in essence, have four instruments that are working in that tongue base. If I had a headlight, it'd be much different. I would have two instruments, just my own hands, and it would be more difficult. So there's a big advantage having an assistant with a robot. So moving to the surgeon's console, the first thing I do is I get in position. And I make sure that my arms are comfortable. I've already adjusted the position of the console itself. It has custom presets, and so this one is preset to my height. And if we look, you see previously, I'll look over here. This is where I performed the lateral oropharyngectomy. If you watched, I also showed how to do a longus coli flap to cover great vessels, and I demonstrated how to use a buccal fat pad to fill in a palate defect. So that's what we have there, and that was from, if you are interested in seeing that webinar, it is recorded and it's on our nicholsoncenter.com website under the Education tab, and you'll be directed to the video. So here we have the tongue base exposed. You see the circumvallate papillae here. We don't see the epiglottis, and that's because I don't want to have the tongue base pushed away. I want the tongue base in view. Today we're going to do a left partial glossectomy, focusing on the left side. Typically, you know, the tumors of the tongue base are left or right. Occasionally you have a tumor that might extend across the midline. That would be a more advanced case. I would say you should have enough experience before deciding to manage or tackle one of those operations. So this case, we're going to work on the lateral tongue on the left side. Sometimes these tumors also extend into the glossotonsillar sulcus or the glossopharyngeal sulcus, and you can extend your operation to include those areas if necessary. And then some tumors are tonsillar tumors, and interesting thing looking at this patient here, this tonsil looks quite abnormal. It looks kind of papillomatous, like you might see in somebody with a tonsil cancer. It's unknown any previous illness with this patient, but this patient has something that could mimic a tonsil cancer on the left side. And sometimes these tonsil cancers can extend onto the tongue base, and so you're going to do a composite resection with a lateral oropharyngectomy and include the tongue base resection as well. Again, those are more advanced cases, and I would encourage those who are interested, make sure that you have the experience necessary, because you certainly don't want to compromise the oncologic operation for the patient. So one difference about robotic surgery compared to transoral laser microsurgery is the technique of resection. In transoral laser microsurgery, the laser is used to divide tumor, and the surgeon goes through the tumor, beyond the tumor, until they see normal tissue to include that margin. And the tumor is taken out in sections and then oriented to the pathologist for position. In TORS surgery, we typically do not cut through tumor, but we remove the tumor in an en bloc resection. And so I teach surgeons who are performing robotic surgery to think of a box. And the tumor should sit inside the box, and you want to take the box out. The box often is very well defined. So the box for the tonsil is very well defined anatomically by muscles. We have the superior aspect is along the soft palate, the lateral aspect is along the medial pterygoid muscle, the inferior aspect is along the tongue base, the posterior aspect is along the posterior pharyngeal wall, and the deep aspect includes the constrictor muscles, the styloglossus muscle, and the stylopharyngeus muscle. If the tumor is inside of that box, the patient is an excellent candidate for robotic surgery. The box for the tongue base is less well defined because we don't have all the different muscles that we see in the oral pharynx. But it could be simply described as the anterior margin being the circumvallate papillae, the lateral margin being the glossotonsillar and glossopharyngeal sulcus, the medial margin being the midline of the tongue base, the posterior, or you could say inferior margin being at the vallecula. And the depth of the dissection could go out to the hyoid if necessary, but typically we want to use the tumor as a guide for the depth. Now, with robotic surgery, I have no feeling when I press here. There's no haptic feedback. So I'm using my eyes to feel. And so you can notice that there's differences between tissue by palpation. You can notice the response of the tissue to the palpation. If I palpate this, for example, where it's being compressed, it's more firm than if I'm palpating this, which is not being compressed. And so the tumor is typically more firm than the surrounding tissue. And so when I'm looking at the tissue, I'm palpating, and if I see that the tissue is not responding like it is here, I may be too close to tumor. And so in that case, I want to go and get above and over the tumor with a deeper margin. So we'll begin. Brandon, can you get a yank hour suction? Just hold it in there for smoke evacuation. Yep, thank you. So I'm going to begin here and get to a position where I like my camera. I like to have it relatively close, take advantage of the magnification. And I'm going to make my anterior margin along the circumvallate papillae. So we have the circumvallate papillae here, and we're going to come along the anterior margin in this manner. So I make my first cuts along the anterior margin. I'm not grabbing typically at this point, because if I do grab the tissue, there's not enough to hold on to, and it tears the edge, and it disrupts the quality of the margin for the pathologist to evaluate. The other thing I want to point out is, if I went straight ahead in this tongue base, I would go obliquely through it. So you have to make sure that I'm going up and over, up and over. So I want to be thinking about going in this direction and not going straight ahead, because then I'll just go obliquely through tumor and I won't get a good margin. So the other thing with the camera is I can turn it and get different views, whatever best suits the need. So many times I use my Maryland dissector not just to grasp and to pull on something, but as a retractor. And so you can see I've turned my tines in this direction. I can open this and I can pull down and retract, and that helps me to get up and over the tumor. So I'll begin again. I make my first margin, and now I'm concentrating by going up. So that I can go up and over the tumor. And as I get ahead of myself, I want to make sure that I get into the glossotonsillar and glossopharyngeal sulcus, and so I will begin to make my lateral margin as well. So let me describe what I'm doing here in terms of my dissection technique. So with the robot, I'll back the camera so you can see a little better. With the robot, there are two styles of dissection. There is the straight stick dissection where the whole arm is moving. I call this laparoscopic technique of dissection. And then there is using the master controls of my hands, I can just move the tip. And if I'm just using my fingers to roll the tip and I'm not moving my arm or my wrist, you see that just the tip is moving and the instrument arm, the shaft of the instrument is relatively still. This is very helpful the more distal you get in the operation, because as these arms are close together, if you're moving them, you're going to have collisions. So by doing this, I'm avoiding collisions. This is what I'd call robotic technique of dissection.
And I just have a question from David Walker.
Yes.
What do you set your monopolar energy to? Also cut, coag, or blend?
Okay, so with the XI system, the question is, what do I have on settings for energy? And with the XI system, it's an Irby generator, and they have 3 settings, 1, 2, and 3. And typically I put the setting on 2, and I have to look at the rest of the settings. So I'm wrong. The setting goes up to 8. So I usually go in the middle and I put it at 4 for cut and coag. And there are different settings. There's an auto setting, and there's a dry setting for the cut, and for the coag there's a swift, a forced, and a classic. And typically I use the classic of the coag. Now in the, there we go, that's why it's different. Let me see. So when I was saying 1, 2, or 3, I use it on 2. That's for the coag. So on the classic, I use a setting 2 for classic on coag. And then for the bipolar, which we don't have turned on because we don't need it today, I would put it, again, it has 8 settings. I usually put it around, I start in the middle, around 4. For the cadaver dissection, because of I don't have to worry about bleeding, I entirely use the cut. I never use the coag, and the difference is it generates less smoke on a cadaver. And so that's why I'm using cut, but typically I would be using, once I make my mucosal incisions with cut, I go straight to coag and I use coag for the rest. So I'm going to connect my lateral incision with my anterior incision. It's best to work with a broad front. Can you push up like that, Brandon? Maybe with your left hand. Yes, thank you. Good. So I'm going to connect my lateral cut with my anterior cut and continue with this broad front. I don't want to get into a hole, because the idea is you want to have excellent exposure. Notice again, I'm using just the tip. I'm rotating my fingers so the tip can go and the shaft is not moving itself. So making my lateral cut along with glossopharyngeal sulcus, glossotonsillar sulcus, and as I get ahead of myself, then I connect my anterior and lateral cuts so that I can stay in a broad plane of exposure. Hold that up, please. Thank you. And do you have the suction in there, Brandon?
Yes, sir.
So we have a broad exposure. Now, what I want to do is I want to come and make sure that I have my medial cut as well. And so in this case, we're going to come right down the midline. Again, this is the general box that we want to take out. And I'm going to connect my medial cuts, my anterior cuts, and my lateral cuts. I'm pushing my tumor down, my tongue base down, and I'm coming up and over the tongue base.
Can I just make 2 questions?
Yes, another question.
Do you get haptic feedback of the tumor?
So the question is, do I get haptic feedback of the tumor? And the answer is no. But what I do is I use my eyes to feel. So if I'm pressing here, I can see how the tissue responds to my palpation. And as I get closer to tumor, it's going to be more firm and it has a different response. It doesn't have this soft response that I see here. And the other question?
How do you manage the lingual artery?
The question is, how do I manage the lingual artery? I'm going to show that here shortly. Typically, the lingual artery is going to be seen in this location, up and out here. And so sometimes in the cadavers we don't see it in the tongue base because there's no blood flow, of course, and the vessels are collapsed. But we'll do our best to look for it. I mean. So back this up a bit, Brandon. There you go. Over here is better. Yep, great. And back that up. Thank you. So again, I'm constantly looking at what I'm doing. I don't want to get in a hole, so I have a broad view. So if you can retract that over like this. Thank you. Excellent. I'm looking at my posterior pharyngeal wall. I'm lifting this up so I can see the glossopharyngeal sulcus. And I continue along my lateral margin. And as I get ahead of myself, then I come back and I work along my anterior margin. Hopefully we'll see the lingual artery. And as I get ahead of myself for the anterior margin, I come and I connect my medial margin. It's very rare to see any sizable blood vessels medially. The sizable blood vessels are all going to be lateral. So medially, I can mostly manage any bleeding with the bipolar Maryland. But as we work laterally, again, and see how I'm keeping my tines open and I'm pushing down, I would be palpating with my eyes and I would see what tissue reaction. Of course, there's no tumor here, but if there was tumor here, this would have a very hard appearance where the whole specimen, you don't have this soft appearance with pushing the tines of the Maryland in. So the dorsal branch of the lingual artery would be coming somewhere along in this area, so I'll do my best to keep track of it. And so when I do see it, just like we would with an open operation, I dissect out. I can use my monopolar as a dissector. I dissect out the tumor, the vessel, and let's say this was the vessel here. It's not, but let's say, I hope we see it, but let's say this was the vessel. My assistant has a clip applier. It's the Karl Storz laryngoscopy clip appliers that we use in TLM surgery. My assistant would come and place the clips over the vessel. Typically, I use multiple clips on the proximal side and in a single clip on the tumor side or the distal side. And I would place those clips and then divide between the clips. But on the source side of the vessel, I would recommend placing multiple clips. You don't want to have a single clip fall off. The other very important thing, especially with tongue-based surgery, is managing the lingual artery in the neck. So a very safe thing to do during the neck dissection is to ligate the lingual artery in the neck. That reduces the flow and the force of the flow from the vessel. You still can have backflow from the contralateral side, but it reduces the flow. And I also recommend not just ligating the lingual artery, but also ligating the facial artery in the neck. And the reason is there can be communicating vessels between the lingual artery and facial arteries. And if you ligate only the lingual, you may have vessels from the facial contributing. So you see I'm going back and forth. I'm rotating my tumor. If I needed to, if I wanted to make sure, I would look at this side and see, am I beyond my distal margin, or do I need to still continue? So I'm heading out towards the vallecula in this case. Again, we would be looking for the lingual artery right out in this area here. With a cadaver, it's often collapsed, so it's going to be difficult. Can you suction some of this fluid, Brandon? Thank you. You notice it seems like I'm always working close to the blade, but that's not the case because this was all the way in here. I just keep pulling the tongue towards me so that I'm bringing the tongue to me. There are times where I have to go and get in to the patient, and then look how I'm grabbing here. I have one tine on the wound side at the top, and I have one tine underneath the tongue so I can get on either side. I'm lifting it up and pulling away. That keeps it from touching or being on the epiglottis. I can also use that as a guide for margin because I know if the tumor's here and I grab here and I cut out here, I have an adequate margin then for that resection. As I get closer to the vallecula, the muscle thins out and we begin to see the epithelium from the undersurface. Following right along my lateral margin. I've gotten ahead of myself, so now I'll take my anterior margin and I'll catch it up to my medial and lateral margins and connect them. Check my medial margin. I'm looking for epiglottis. Any questions? No, no questions. Okay, we'll keep working. Notice how I'm doing this hand over hand thing. So I may hold my specimen with the monopolar so I can reach over top then with the Maryland. That's called a hand over hand dissection. Looking here, can you suction here, Brandon? Just trying to see if I could see a vessel. I'm holding it in position with my monopolar so I can get my Maryland a little bit in better location. Adjust my camera. Hold it in place. Readjust my monopolar, my Maryland. Thank you. The suction's in my view. The suction seems to be quite weak. Can it go on a higher setting? Okay. You see, I'm pulling the tongue to me as I continue to go more distally. Here is our epiglottis. So I've taken that into the vallecula. Now, as I make my final cut, you see the epiglottis there. As I make my final cut, next thing I do is, as I back my camera out a bit, I reposition the specimen so that I keep my orientation. Many times your specimens can be twisted and flipped and turned, and if you take it out directly and put it on the back table, you miss your orientation. And so here I can now grab the anterior margin so that as I remove my specimen and take the camera away, I can hand it to my assistant who grabs exactly where I'm holding so that I can go to the back table and then ink the specimen properly. So I would take that to the back table, I would inspect it, I would palpate it with my hands, I would look at margins, I'd look at epithelial margins, I'd palpate for deep margin, and then I come back to my wound and I inspect for bleeding. I look for any pulse. If I see a pulse, I have to manage it, maybe with clips. If there's some bleeding, I can come with a bipolar and I can press on the bipolar and cauterize. And then if necessary, I can come back. I can take additional margins from the patient if I feel like this lateral margin is compromised. Or if I need a deep margin, I'd back the retractor blade up and I'd get a better view, because now I've lost my view of my anterior margin, the circumvallate papillae, as the tongue was retracted in. If I need to and I have to have more, I can back the retractor blade up and get another margin. Again, if I need a medial margin, I come back and take another piece of the medial margin. So I inspect the patient, I inspect the primary specimen. I may or may not have the pathologist do a frozen section test on the primary specimen, but sometimes I also take margins here from the patient and I have the pathologist check a margin that I'm taking directly from the patient. So it depends. The margin, checking the margin is, I don't have a general rule. I do what I think the tumor fits for the best situation. Now, we leave this wound to heal by secondary intention. There is no suturing, there's no closure of this wound. And I have found that patients have difficulty with swallowing mainly because of pain, not because of inability, but mostly because of pain. And so in that case, with these patients, I place a nasogastric Dobhoff tube. I secure it to the nasal septum And then the patient has that nasogastric Dobhoff tube as a backup to supply nutrition, to supply fluids so they avoid dehydration. In the United States, we tend to discharge patients quickly, and I discharge my patients generally on postoperative day 1. They go home with the Dobhoff tube. The nurses teach the patient and the family members how to use the Dobhoff tube. We have a dietitian who prescribes how much fluid the patient requires and also the nutrition requirements, and they typically get a liquid nutrition that goes through the tube, and that the calories are prescribed by the dietitian. And they go home with those instructions to return a week later in my office where they have a session with my speech pathologist and they have some dysphagia therapy. And typically we remove the Dobhoff tube on that postoperative visit. So that's generally the routine for these patients. Occasionally we may keep the patient 2 days in the hospital, but generally they stay for 1 day. So we have a question.
How do you ensure not breaching the mylohyoid when coming onto tonsillolingual sulcus?
So the question is, how do I ensure not to breach the mylohyoid when I'm coming onto the tonsillolingual sulcus? If the neck dissection is done simultaneously and we have a communication from the pharynx into the neck, many times you can close that primarily or even use the submandibular gland, immobilize the submandibular gland and use that submandibular gland to plug the hole. You can use the digastric muscle as well as a muscle flap in the neck to plug the hole. So typically if I can close the hole primarily, I'll do that. If not, I use a submandibular gland and I use the gland to close around the gland and suture directly to the submandibular gland. Typically then I place an acellular dermal matrix like Alloderm over that and some fibrin glue. And we haven't had any issues with fistula in that case. If the neck dissection is done separately, that is, say, if I ever do a neck dissection, I typically, separately, I always do the neck dissection first. That way I can go and I can ligate the vessels in the neck so that the next week I go back, or 2 weeks I go back and do the primary resection. In reverse, if you do the primary resection first and you don't do the neck dissection until a couple of weeks later, you're at risk because you haven't ligated the lingual and facial arteries. So if I breach the mylohyoid, it depends on if there's a communication, it depends if there's concurrent dissection with the neck. There is a question, may I have the link for the technique for longus coli flap to cover the vessels? And so again, if you go to nicholsoncenter.com, education videos, we have the videos there listed to view. We have just 5 more minutes. Here's another question. What are your feelings on glossotonsillar sulcus tumors which have recurred following radiation? So this is a very good question. So that is a danger zone. And the reason why that's a danger zone is right in the glossotonsillar and glossopharyngeal sulcus lies the great vessels. If you're superior, you're going to be working very close to the facial artery, lingual artery. If you're more inferior or distal in the aerodigestive tract, you're going to be even close to the external carotid artery, the common carotid artery. You may, if you have a medialized internal carotid artery when you're up high, you'll be very close to that. When patients have had radiation to the oropharynx, they lose that fat pad that's between the constrictor muscles and the vessels. And that fat pad is very protective. And so if you're going to do a glossotonsillar glossopharyngeal sulcus resection as a salvage operation in a salvage setting, I don't recommend robotic surgery in that case. And I don't recommend allowing that wound to heal by secondary intention because you're placing the patient at a very high risk for a catastrophic bleed with a rupture of one of those great vessels. In that case, I recommend that the patient have a microvascular free flap reconstruction so they have healthy, non-radiated tissue covering their wound. Otherwise, the healing process is going to be very, very difficult and very dangerous. There's a question, when are the ligating clips removed? So I don't remove the clips. So when they're in the neck, they're titanium clips, they stay there forever. When we ligate in the oropharynx, the clips fall off at some point because when we go back and look later or if they're imaged later, there aren't any clips there. So at some point, the clip falls off and they just swallow the clip and pass the clips through the intestines. They're only 4 millimeters, so they're very small clips and they cause no problem. But we don't remove any clips. They just either fall off or they stay permanently. So with just a couple minutes left, I have a couple of announcements. If you're interested to watch part 3 of this mini-series, on October 5th, which is a Monday, 4 to 5 p.m. Eastern time here in the U.S., I'm going to perform a supraglottic laryngectomy. So if you're interested, you may join. If you have the time or the opportunity, you may join for that broadcast. We also have some partners at UCLA. Dr. Eric Dutson and his colleagues have 2 robotic skills webinars planned. The first is Monday, September 14th. That's this next Monday at 1 p.m. Pacific Standard Time. And also the part 2 of the robotic skills is Wednesday, September 23rd at 11 a.m. Pacific Standard Time. So those are on our website as well. If you're interested to see those with our colleagues from UCLA, Dr. Eric Dutson and his team are going to hold those webinars. And finally, again, I want to thank Olympus for helping us sponsor this program. I'll take a quick look. There is a question about flow seal or in the open wound. I used to use it, but I believe that the patient ends up swallowing it. If there's some generalized oozing, I'll still put it in there, but as a general rule, I don't use it anymore. So thank you, Olympus. Thank you, participants who've been on this webinar series, and I'll say goodbye.